conversation here with Dr. Nathan Bryan. I think this conversation had to happen because our paths have crossed a couple of times.
Yeah,
And we were in Houston. No, it was Austin actually. We were there about 2 or 3 weeks
awesome.
ago. Austin in Texas. And I didn't realize you were there, but I went looking for your stand. And lo and behold, you were there. So I said, great, why not strike while the iron is hot? So, what are we going to be talking about here? We're going to be talking about a gas called nitric oxide. So, people, when they think about gases, they think about oxygen and carbon dioxide. But what about the third gas? What does it do? Where is it formed? Why should we be thinking of it? So, we have probably the best expert in the world in terms of this topic. So it's a pleasure, Nathan. I have plenty of my own personal questions to ask you as well. So, I think this is going to be a good conversation. Can I just
Well,
ask
no
how,
problem. Yeah, thank you, Patrick.
I'll start off, like, I suppose, a little bit about your background, but I'm more curious, why did you go down the kind of rabbit hole of nitric oxide? Like, what got you there?
Yeah, no, it's a good question. It's a common question, but I've always had an interest in science and medicine, even going back to high school. But out of high school, I went to the University of Texas at Austin. I got a bachelor's degree in biochemistry, and then I went to LSU School of Medicine, and it was there that I was introduced to this whole field and new science around nitric oxide. This is a Nobel Prize had just been awarded for the discovery of nitric oxide. So the scientific community was really excited about this new discovery, a relatively new discovery. And, early on in my PhD work, I met Lou Ignarro, who came and gave a lecture on nitric oxide. He had just won the Nobel Prize and came to the LSU School of Medicine and gave a lecture and kind of his his story, personal story of discovery of, how he discovered that EDRF is nitric oxide. And, I had a chance to have dinner with him that night, and he made a very profound statement that I'll never forget. And he says, Nathan, he goes, this is such an important discovery. He goes, if anybody or any company can figure out how to restore the production and natural signaling of nitric oxide, it'll change the world. Because we know that most chronic diseases are associated with a loss of nitric oxide production. So there's still a lot of work to be done. And so I go, wow, that's really a profound statement. And I worked with a pharmacologist, Martin Feelish, who was my PhD mentor and advisor. And, we got to work. And, even as a student, I think I finished my PhD in about 2 years, published, I think, 6 first author papers, because we'd figured out how to detect nitric oxide gas at physiological levels. So that gave our research group a very powerful tool to make new discoveries around nitric oxide. Once it's produced, where does it go? What does it become? And what does it do? And then I went to Boston, did a 2-year fellowship at BU Medical Center, and really just still trying to understand the vascular production of nitric oxide and how do we restore the production of this. And then from there, I was recruited by Fred Murad, one of the other guys who won the Nobel Prize, to join the faculty at University of Texas Medical School in Houston. And, we were at a center called the Institute of Molecular Medicine, where we were charged to really understand the mechanism of disease to the extent that we could fix it through development of rational therapies. So that was, I was introduced to this field in the late 90s, early 2000s, and, that's all I've done for the past 25 years.
Wow, wow, wow. So nitric oxides, you're talking about the late 1990s. So the
Right.
award for the Nobel Prize for Medicine, Ignaro, he received that, I think, in 1998. It's a really
Okay.
relative recent discovery, but I also believe that when they first thought about nitric oxide and when Ignaro started giving talks to a conference, it wasn't always best received. Nitric oxide was it was kind of dismissed, really, and then it was embraced.
No, for sure. I go back to the, late 80s when they first administered nitric oxide gas to premature babies with pulmonary hypertension. And, I was very fortunate to know Warren Zapal, the anesthesiologist, and a lot of his team at Mass General and Harvard Medical School, where they were administering nitric oxide gas. And, they said, because if you have a cylinder of nitric oxide gas, very clearly on that cylinder, it has a skull and crossbones and it says poison. So you can imagine the general population, when you were going to administer the most vulnerable patient in the world, a premature baby that's, living on the brink of life or death, and you're going to administer a gas that clearly says poison on it. But now fast forward, and we know that inhalative nitric oxide therapy for premature babies with pulmonary hypertension is very effective. And it's not only effective, it's very safe at the doses you administer. So now we know that, I mean, those are paradigm changing observations and discoveries. And that's why nitric oxide is so important, because now we need to figure out how do we deliver this in an outpatient setting and how do we restore the natural production of nitric oxide. I think that's what you've done such a fantastic job of doing is, teaching people that just nasal breathing can activate and stimulate the production of this very important molecule. So you don't even have to give it through inhalative therapy. We can just do the nasal breathing and deep breathing exercises and naturally produce it.
And it was a nice lead in. So, young infant babies who have pulmonary hypertension, so they were breathing in the gas, obviously, to increase or to carry that nitric oxide into the lungs. And the purpose in the lungs was to help to dilate the little blood vessels to reduce pressure.
That's right. So the nitric oxide, so when we're delivering it intranasally, nitric oxide's a gas, right? So it just diffuses right across the bronchioles into the small blood vessels of the alveoli, the lower airways. And so the problem in pulmonary hypertension, and it's a problem in premature babies, and it's a problem in adults with pulmonary hypertension. So what happens in the lungs, and the lungs are a very unique organ because typically when you have hypoxia or low oxygen, all other organ systems dilate because we need to get more oxygen to that tissue. But the lungs are a little bit different because if they're poorly perfused regions of the lungs, then you get what's called hypoxic vasoconstriction. So if you have pulmonary hypertension, certain parts of the lungs aren't being perfused, so you can't take up oxygen. And babies become hypoxic, they become cyanotic. It's called blue baby syndrome. And the nitric oxide completely, corrects that because it dilates the pulmonary arteries, it improves oxygen uptake, it improves oxygen delivery, and that's how it works. And the same mechanism is in place naturally through nasal breathing and through endothelial nitric oxide production. The problem in adults is just they've lost the ability to produce nitric oxide, so it's no longer uh, generating nitric oxide when we do nasal breathing or when we activate the endothelium.
So, in terms of then nitric oxide coming from the nose, I believe it's produced locally in the nose and it's also produced in the paranasal sinuses surrounding the nasal cavity. And say, for example, we went through COVID and I was putting out blog posts about the importance of nasal breathing. At least in Ireland, all of the emphasis here was about washing hands and wearing a mask. Nobody was talking about breathing in and out through the nose. And I was thinking about like if this is a virus that's transmitted airborne via water particles, it doesn't really make sense for us to be going around with our mouth open. Either the person who is infected because they're breathing more particles out into the atmosphere, but also for the person that's close to them, if they have the mouth open, they're bypassing the nose. And people kind of objected to what I was saying. And I was saying, listen, your nose is kind of the first part of defense. So, will you list the functions of why this gas is very important? And it was only in 1991 that the nitric oxide was first identified on the exhale breath of the human being. So, it's still relatively recent. What are the functions in terms of nasal nitric oxide? And do you think there may be other functions of nitric oxide when it comes to sleep apnea, but yet people aren't really talking about them?
No, absolutely. Look, we have to understand the enzymology and the biochemistry of that reaction because there's an enzyme, the same enzyme that's found in our endothelial cells, and those are the cells that line all blood vessels throughout the body. That enzyme is also found in our epithelial cells. In fact, the highest concentration of this enzyme is found in our nasal epithelium. So we have to focus on how does that enzyme become active so that when we activate it through nasal breathing, it actually produces nitric oxide gas. And we understand the enzymology and the biochemistry of that reaction. So the problem is in older patients, when we have endothelial dysfunction, you also have epithelial dysfunction. And you've probably seen this in the published literature that young, healthy people, if you do nasal breathing, you get exhaled nitric oxide, or you get nitric oxide that we can detect in the exhaled breath. But if you take older patients with hypertension, diabetes, erectile dysfunction, they can do nasal breathing, but there's less nitric oxide being produced that we can detect in the exhaled breath. And the reason for that is because their enzyme isn't functional. So that's really the work I've been doing for the past 20 or 25 years. How do we fix the enzyme? How do we restore the oral microbiome so that the body is optimized to naturally produce this molecule? And so if we can recouple the enzyme, now when we do nasal breathing, we can detect more nitric oxide. And when it's produced in the sinuses, again, it's just like giving it through a nasal cannula. It's delivered into the lower airways, it dilates the blood vessels, it matches ventilation to perfusion, and it's a normal physiological response. Now, your question to patients with sleep apnea, for this enzyme to work, it's really a complex enzyme. It requires 8 different cofactors and substrates in order to convert arginine to nitric oxide gas. One of those is oxygen. So if you have sleep apnea and you become hypoxic, which is a result of sleep apnea, lack of breathing, then without oxygen, your body can't make nitric oxide. Without nitric oxide, you can't deliver oxygen. So it's this feed forward loop that if you don't correct, you can get into really serious conditions. And the numbers. People with obstructive sleep apnea have, sometimes a 10-time higher risk of cardiovascular disease, heart attack, and stroke. So oxygen's important, but I think nitric oxide is even more important because, as you said during COVID, you put people on 100% oxygen if they become hypoxic, and many people didn't improve their blood oxygen saturation because that revealed to us that they weren't really out of oxygen. They were out of the ability to produce nitric oxide to adequately uptake oxygen and then deliver it to every cell in the body. So nitric oxide is critically important.
In terms of other functions of the gas, so when we're breathing in through the nose and we're carrying that air laden with nitric oxide into the lungs, but when the gas nitric oxide arrives into the lungs, what would you say are the most important? I'm just thinking about all of the people with asthma, but everybody in terms of lung health and gas exchange. What do you think would be the most important functions?
Well, its most important function, I shouldn't say most important. Perhaps its most well characterized function is a smooth muscle vasodilator or smooth muscle relaxant. And so the airways, the upper airways, the lower airways are surrounded by smooth muscle, right? So when nitric oxide is delivered into the lungs, it dilates the smooth muscle. So bronchioles dilate. So now we're eliminating or reducing the resistance in the airways, right? And gases follow the path of least resistance. So we're lowering the peripheral vascular resistance. We're lowering the resistance in the airways, and when it's delivered into the vasculature, when it diffuses across the airways into the circulation, it's now dilating the blood vessels. So now you're matching ventilation to perfusion, which is a normal respiratory response. So that's number one. But number two, in terms of our immune system, nitric oxide inhibits a virus from replicating, most respiratory virus, whether it's a coronavirus, whether it's RSV, whether it's influenza. If our body makes sufficient nitric oxide and we're breathing nitric oxide, then the virus can't attach to our cells, it can't propagate and replicate in the cell, and we don't get sick from virus. I haven't been sick from a viral infection in more than 20 something years. All 4 years of COVID, I never got COVID. I never wore a mask. I was on an airplane every week. We had 26 clinical sites for a COVID drug study we were involved in. I didn't get the shot, and I've never had COVID. So that just tells me that if our body's making sufficient nitric oxide, specifically with COVID, it downregulates the ACE2 receptors, which is where the spike protein binds to and attaches and enters the cell. So it makes perfect sense. It improves circulation, we mobilize an immune response, and we prevent virus from replicating.
Okay, so keeping that simple in terms of people who are listening that may not understand the words, but so really this is a gas that can help open up the airways. So the sensation that people might have of chest tightness or wheezing or difficulty in breathing, and we have the bronchial tree, which is an extensive network of airways. I think there's about 23 branches in total. So as we're drawing that air, that nitric oxide from the nose and gently carrying it into the lungs, it's helping to open up the airways. And then the blood vessels. So when that air then arrives to the small little air sacs in the lungs for gas exchange to take place, nitric oxide crosses the barrier from the lungs, the small air sacs into the blood, and then it's dilating the blood vessels. So nitric oxide is going into the blood, and now that blood is going to the heart So here's a question that has always kind of bugged me, and you know what I'm going to ask you. The heart then is pumping that blood, but is nitric oxide having an impact on that circulation?
The
From
answer is
from the
yes.
nose, sorry.
Yeah, the answer is yes, but it's not nitric oxide gas itself. So in these data were published because it was first thought that if you give inhalative nitric oxide therapy, it was a selective pulmonary vasodilator. But and we did this studies when I was in Boston in collaboration with Mass General and looking at the systemic effects of inhaled nitric oxide. So nitric oxide, once it's produced, whether it's in the nasal epithelium or whether it's in the lining of the blood vessels, typically it has a half-life intravascular. I mean, if it's produced in the lining of the blood vessel, it has a half-life of about 2 milliseconds. So 1/5 of a second, right? And then if it's produced outside the vasculature, like in the airways, it has a half-life of maybe 2 seconds. But what happens, and this was part of our work early on in the early 2000s, because I was interested in once nitric oxide is produced, where does it go and what does it become? And then how is it transported throughout the vascular tree? And so what we found was there's two main transporters. One, it's oxidized to inorganic nitrite with the dioxygen reaction. And then number two, it binds to the cysteine of glutathione. Right, so glutathione is a master antioxidant. It's a tripeptide, 3 amino acids, and one of those is a cysteine, which contains a sulfur residue. So nitric oxide binds to the sulfur residue, and then it's transported throughout. So, there's millimolar concentrations of glutathione in the red blood cell. So once nitric oxide is produced, it binds to it. There's cysteine in the plasma, and then it can be transported. So to answer your question, if we're breathing in nitric oxide or producing nitric oxide in the lining of the blood vessel, it's systemic because it forms inorganic nitrite, it forms S-nitrosyl glutathione, and it transduces that vascular activity from the site of production, whether it's the lungs, or the site of production, whether it's in the endothelial cells of the sex organs or the heart or the brain. It goes systemic. And we actually published on that in 2007 in the Proceedings of the National Academy of Science, showing for the very first time that nitric oxide is a hormone. And that's the hormone, that's the endocrine function of nitric oxide. So that was really the eureka moment for me in science because I knew that if nitric oxide is a hormone, then in people who were low in that hormone, which is the aging population, people with erectile dysfunction, high blood pressure, diabetes, then we had to replace that hormone. And so all we have to do is generate nitric oxide in a single compartment, whether that's the upper airways, whether it's the oral cavity, which is where I focused, or whether it's stimulating through the production of exercise or through dietary changes. And now, once we produce nitric oxide, it goes systemic. And we no longer have to deliver it just in a nasal cannula in an inpatient setting, especially in a critical care setting. We can do this in an outpatient setting. We can teach people to do this every day to replace the missing hormone, nitric oxide.
So, in essence, this is only my interpretation on it because I got a little bit lost along the way. So, nitric oxide has a half life of about 2 seconds, you're saying, from the lungs into the blood. So, it means that half the gas is gone within the 2 seconds and only 50% is remaining. But because the gas makes some conversion in the blood vessels, it's still able to do a lot of work throughout the body. So, it's irrespective of the short
Well,
half-life.
yeah, so let's go back because once nitric oxide is produced, it's called a messenger molecule or a signaling molecule. So even in that second or less that it's around, it activates an enzyme called guanylyl cyclase, and that enzyme leads to cyclic GMP, which now is a second messenger. So once it's produced, it starts this signaling transduction. And the analogy is if you've got, a string of dominoes, and once you hit that first domino, then the dominoes fall, right? So you can knock that first domino over in less than a second, and then all the other dominoes are in line are going to fall. Nitric oxide is that first domino, right? So it doesn't have to, all you have to do is turn it on. And then it activates these second messenger systems. It's transported, it's oxidized by oxygen, it binds to other cysteine residues, and then it's transported throughout. But it's that first domino in that cascade.
But this is shocking now because now I'm beginning to wonder, okay, we've been talking about the benefits of nose breathing versus mouth breathing. And we've isolated everything in terms of the impact of nasal breathing on the airways and the lungs, which of course is very, very important. But what you're saying is having way more effects than just isolated to the lungs. And my question
Absolutely.
then, Nathan, is what about mouth breathers? I was a chronic mouth breather for so many years. 25 to 50% of studied children are mouth breathers. We don't have many stats for adults because it doesn't get really studied. 50% of adults breathe through an open mouth during sleep. So we have this gas that's hugely important in terms of health. But by bypassing the nose, we're not going to be getting the same benefits of the gas by breathing through the mouth. Because I don't know if I'm correct here that the production of nitric oxide in the nose is 100 times that of the lower airways. So the main source in terms of the airways is the upper. So here's the question in a general sense. What would be the more common conditions that may be associated with mouth breathing because that mouth breathing is contributing to because it's bypassing the benefits of nasal nitric oxide?
Well, we know there's a hierarchy of symptoms that develop and the progression of a gradual loss of nitric oxide production. First, you see erectile dysfunction, and this is in both men and women. And you think about this because if your body can't produce nitric oxide to dilate the blood vessels of the sex organs, then we can't get an erection. And that's both a clitoral and a penile erection. So that's number one. And we call that the canary in the coal mine because it's the first sign and symptom. And then number two, your blood pressure goes up. At least in the US, I think it's probably global statistics, but 2 out of 3 Americans have an unsafe elevation in blood pressure, right? And we're finding that it's because of a loss of nitric oxide production. And then the third is you start to get metabolic disease. 9 out of 10 Americans are metabolically unfit because we published in 2011 that nitric oxide is required for insulin signaling. So, and to get glucose into the cell. If the cell can't make nitric oxide, you get insulin resistance and you get diabetes. And then number four, you start to develop exercise intolerance where you tire easily. You get short of breath walking up a flight of steps. And then if not corrected, then people start to get heart attack, stroke, vascular dementia, and Alzheimer's. So the interesting thing about mouth breathing is you're not only bypassing this essential pathway to produce nitric oxide, but you're actually inhibiting it more so because when you fully oxygenate the oral cavity, that completely changes the ecology of the oral microbiome. It creates a more acidic environment. Your saliva becomes acidic. It changes the ecology. Now you have more opportunistic infectious bacteria, the gingival bacteria, prone to cavities and caries and periodontal disease, gingivitis. So we have to close the mouth, change the ecology, do the nasal breathing, not only stop preventing, inhibiting the nitric oxide production, but promoting it through nasal breathing. So mouth breathing is one of the worst things we can do for our cardiovascular nitric oxide production.
Okay, I'm going to kind of hold with that point in terms of mouth breathing. So because the mouth is open, we're taking cold, dry, unfiltered air into the mouth, and this would dry out the mouth. So this, what you're saying is this is changing then the bacteria inside the mouth. And of course, then you're thinking about the connection between the mouth and the gut. So every
That's right.
time we swallow or the food that we eat, we're carrying this bacteria then from the mouth into the gut. So it's affecting the gut microbiome. So what's happening there? Um, just a little bit about that. So that's one question to tease that out a little bit. Because again, nobody seems to talk like there's a lot of talk about gut microbiome at the moment, but there's not so much talk about breathing in and out through your nose to help with the gut microbiome.
Yeah, so we and others identified these, what we call the oral nitrate reducing bacteria that live on the dorsal part of the tongue. So these non-pathogenic commensal bacteria are part of our natural production of nitric oxide. So, and it explains the benefits of certain diets, a Japanese diet, a Mediterranean diet, the dietary approaches to stop hypertension. So when we consume, it's primarily green leafy vegetables that contain inorganic nitrate. When we consume these foods, 90 minutes later, the nitrate is concentrated in our salivary glands. So now each time we salivate, if we have normal salivary flow, then it's providing these bacteria on the dorsal part of the tongue nitrogen to respire on because they're facultative anaerobes. If they don't have oxygen, they use nitrogen in the form of nitrate and they reduce that to nitrite. So now we swallow our own saliva, we get nitrite becomes protonated in the lumen of the stomach. So now we're getting nitric oxide being produced in the lumen of the stomach every time we swallow our saliva. And that nitric oxide has been shown to kill H. pylori, the ulcer-causing bacteria, kill E. coli, Salmonella, botulinum, Clostridium, all of these foodborne pathogens. And it's increasing gastric mucosal blood flow because similar to nitric oxide delivered in the lungs, the nitric oxide delivered in the stomach dilates the blood vessels, it diffuses across the mucosa, and now we're enhancing nutrient absorption. But if you're not eating a good diet, if you don't have the right oral bacteria because you're a mouth breather, because you're using fluoride toothpaste or using antiseptic mouthwash, or you're taking antacids, which is a huge problem, then you're completely eliminating this natural production cycle of nitric oxide. And we know, if you use mouthwash and kill the bacteria, your blood pressure goes up. So all of this is very well characterized in the published in the basic science and the clinical literature that this is an absolutely essential pathway. And if we abandon it, we do it to our own demise.
Okay. So my daughter went to her dentist and he advised her to start taking mouthwash. And of course, I was at your talk at the AAPMD, and here's this going off in my head. This is not the right solution. Um, so because I remember you talking about that, people who were taking mouthwash, it drove up their blood pressure. How quickly did it happen? And also, if then somebody say, is that just mouthwash, or is it the fluoride that's in normal toothpastes? Is it the fluoride that's in the water that we're drinking? So,
All of the above. Yeah, because fluoride, look, there's chemical antiseptics like chlorhexidine, which is used by dentists for chronic halitosis and dysbiosis. There's alcohol-based mouthwash that's again antiseptic, and you see it on the TV commercials. It kills 99.99% of the oral bacteria. I mean, 100 years ago, maybe that was a good idea, but that was long before we knew that there was a microbiome, bacteria that lived in and on our body that regulated many human processes. So we know that if you take an antibiotic, in fact, there's no physician today that would recommend anybody take an oral antibiotic every day for the rest of their life, sometimes twice a day. Because now we know that it kills the good bacteria in the gut, causes systemic disease. And so by the same argument, why would any dentist recommend you use a stringent antiseptic twice a day in the form of a mouthwash? Because we're killing the microbiome, we're shutting down nitric oxide production, blood pressure goes up, and you're on a very slippery slope to the onset of cardiovascular disease. And the frightening thing is it's not just the antiseptic mouthwash, it's the fluoride that's in toothpaste. It's the fluoride that's in many municipalities in their drinking water. Why do they put fluoride in the drinking water? To kill the bacteria in the pipes. Well, when we bathe in this, we cook in it, we drink the water, it's killing the bacteria in our pipes, right? In our GI system, in our mouth. It's awful. And we have to do better because the science has advanced to the extent that you cannot ignore the data. And now I think, at least in the US, this is part of the conversations now with policymakers to get fluoride out of the drinking water. I spoke before the American Dental Association last year, and I think we're finally getting the attention of the American Dental Association to change their practice, because you can't do things today that you did 100 years ago and ignore the new science. And in fact, the higher courts in the US have recently ruled that fluoride exposure poses an unreasonable risk. In fact, it's lowering IQ in young kids. So it provides no benefit in terms of oral health, and it's all risk. And you can't subject the general population to unreasonable risk. And it must be removed from the water supply. It must be removed from toothpaste and mouth rinses. I think we have to get rid of these.
Point two that you made was, say, erectile dysfunction, and I'm sure there's plenty of men my age, and I think you're in close enough age to myself, age 50s, but even age 40 plus. And of course, this is going to grab their attention. So you were talking about nitric oxide and the role, but you said that it's the canary in the coal mine. So what does it mean? So if a man, say, for example, is waking up in the morning, but he doesn't have an erection, and normally it should be that a man is waking up, that they have morning wood, to have an erection. But if he doesn't, what's the bigger picture there?
Well, it means he has systemic disease because, again, if you're not dilating the blood vessels of the sex organs, then that tells us that vascular bed and the blood vessel can't make nitric oxide. But it's not unique to the vascular bed of the sex organs. If you have endothelial dysfunction in the blood vessels that perfuse the sex organs, that same dysfunction occurs in the blood vessels of the heart, the brain, the liver, the kidneys. It's a systemic problem. And so we have to, and if you treat it as a lifestyle disorder, then it's grossly underappreciating the systemic nature of that disease. And so we have to focus and we have to get physicians and urologists and endocrinologists and primary care docs to recognize that as a symptom of nitric oxide deficiency. And today there's enough data showing that men with erectile dysfunction have a higher incidence of heart attack, stroke, and rapid progression of cardiovascular disease. And it is the canary in the coal mine because, that analogy goes back to, if there's, poisonous gas deep in these mines that send a canary in there. And if the
Mm,
canary died, they're more sensitive to it. Then it tells us, well, we might not be responsive to it or notice it, but there's something bad happening.
yeah.
And we must, mitigate the situation.
So the entire, is it 50,000 miles of blood vessels in the human body are influenced at, in other words, they're not as dilated, or there may be, is there an accumulation of plaque? Is it like what's a little bit more?
Well, the blood vessels are vasoreactive, right? So the blood vessel dilation is a balance of vasodilators versus vasoconstrictors. Nitric oxide is the main vasodilator. So if we lose the ability to produce it, we no longer dilate the blood vessels. So now we have basically adults have a finite amount of blood, volume of blood pumping through these 50,000 miles of blood vessels. And so if we're chronically constricted, then we've got that same fluid going through smaller pipes. And that's just basic physics, right? Pressure will go up. Pressure has to go up. It's fundamental laws of physics. So if we can restore the production of nitric oxide, we can dilate the blood vessels. Now we've got the same volume of blood going through wider pipes. Pressure comes down.
Yeah.
And high blood pressure is the number one risk factor for the number one killer of men and women worldwide, which is still cardiovascular disease. So nitric oxide fixes the physics problem of hypertension. And that's why it's so important, because if we can eliminate the number one risk factor for the number one killer of men and women worldwide, think about what that does for public health.
It's huge. Um, so coming back to nasal breathing, we talked about nose breathing, and when people think about breathing in and out through the nose, they're thinking about, well, when I'm watching TV, my mouth is closed, or if I'm at work, my mouth is closed. Do you have any thoughts in terms of doing moderate intensity physical exercise? Should it be through the nose or mouth? Would that be beneficial? The 50% of people, of adults that sleep with their mouth open, could the 6 to 8 hours of sleep with their mouth open, waking up with a dry mouth in the morning, I assume that that's going to have just as big as an implication as if they have their mouth open during the day.
No, absolutely. I mean, whether you're asleep or awake, that oxygen is getting in, it's changing the ecology, the microbiome, creating an acidic saliva, creating dry mouth, which again changes the entire ecology of the oral microbiome. But yeah, what I do, and look, I'm probably like you, I practice kind of different things to figure out what works. So I like the high intensity interval training, only doing nasal breathing, right? So every morning when I get up, I do 100 push-ups and 100 squats.
Good
And
for
sometimes
you.
I'll
Wow.
no, look, it's amazing the effects you feel and how it starts your day, because you get your blood going, you're fully oxygenating, you get your heart rate going, and we're starting the day with a boost of nitric oxide. And so I think it's a very good exercise, whether you have to tape your mouth. What I do is I get a device, an appliance I put in my mouth that forces me to do nasal breathing while I'm doing the high intensity interval training. And I encourage everybody to do that because, we used to say 20 to 30 minutes of moderate physical exercise is enough to stimulate and activate nitric oxide production. Then people go, well, I don't have 20 or 30 minutes today. Anybody has 3 to 4 minutes, right? I can do 100 push-ups and 100 squats in less than 4 minutes. And look, it's intense, right? Your heart
Yeah,
rate goes up.
yeah.
I start to sweat. Your breath rate increases. So you don't have an excuse anymore. And even if you're brushing your teeth for 2 minutes, I used to do squats while I'm brushing my teeth. That's 2 minutes. Anybody can do that. So
Yeah,
what we call stack the hack, right? You have to
totally.
you have to be
Absolutely. Yeah.
multitask.
Yeah, yeah. And I think like if somebody's kind of new to this and they're hearing this for the first time, um, it might have to use a nasal dilator. So for example, I have a deviated septum, so I use a nasal dilator. And also at the start, kind of just push yourself, but at an intensity at which you can sustain comfortable nasal breathing. Because I'm sure when you started, you didn't manage 100 press ups and 100 squats the first time you did it, but you were able to
Now you have to build it.
adapt over a period of time. So that's amazing. That's brilliant. So
Yeah.
sleep. So this is all new. This is great stuff for us as well in terms of the application going one step further with nasal nitric oxide. Here's another question I have for you. Um, I'm often kind of wondering about the nitric. So, say for example, people with asthma, which is typically characteristic of inflammation in the airways, that the walls
Right.
of the bronchioles have swelled up, and that one gauge of inflammation in the lower airways would be nitric oxide on the exhale breath. So the fraction of expired nitric oxide, is it FeNO as an inflammometer, a marker of inflammation? What's your take on that? Because I'm kind of confused on that.
Yeah, I think look, it's the exhaled nitric oxide is a clinical measure of the severity of asthma. Those exhaled nitric oxide analyzers have been around or detectors for probably 20 or 25 years. So, but the problem is it's the compartmentalization of the nitric oxide. So that what we're detecting in the exhaled breath of asthmatic patients is a reflection of the systemic or the local inflammation in the airways. And I believe we published on this, I believe in 2004 in chronic inflammatory disease, which is what asthma is. We were looking at inflammatory bowel disease or ulcerative colitis and looking at the acute overproduction of nitric oxide in an inflamed tissue. And what we're finding is that it completely inhibits the vascular and the constitutive isoforms of nitric oxide. So chronically inflamed patients or chronically inflamed conditions have maybe more nitric oxide being produced at the local site of inflammation, but systemically, it completely shuts down its production.
Okay.
And so in asthmatics, you get the local inflammation in the airways, but it's shutting down the perfusion of that part of the lungs, and you're getting a mismatch in ventilation to perfusion. Patients become as hypoxic or anoxic in worse conditions. And so if you can give nitric oxide, it dilates the pulmonary arteries. Nitric oxide actually is a very potent anti-inflammatory molecule. In fact, one of my patents is on a method of reducing inflammation as we measure by C-reactive protein in chronically inflamed patients. So it's a compartmentalization issue. So even though they're exhaling more nitric oxide, reflective of the severity of asthma, the underlying problem is really a loss of nitric oxide in the endothelium, in the pulmonary circulation. And that's what's leading to a mismatch in ventilation to perfusion and lack of oxygenation.
Okay. I need to kind of tease it out from my own head now. So, is it a matter of how the nitric oxide is produced? There's different isoforms. So, there is a nitric
Exactly.
oxide that originates because of inflammation called inducible nitric oxide. And this is the
Correct.
bad guy. Whereas we have neuronal nitric oxide, endothelial nitric oxide are good guys. So, if we have inflammation in the lungs, we're producing a lot of the bad guy, and that's impacting the good guy. Is it?
Absolutely. No, you're right. So the,
Okay.
the inducible the inducible nitric oxide is there, and it's a very important mechanism because now we can knock out these specific isoforms in mice. And so if you knock out the iNOS in mice, they become more susceptible to infections. In fact, they're completely immunocompromised. So think about this: when we're exposed to a bacterium or a virus, and our body recognizes that, we mobilize an immune response, we activate monocytes, neutrophils, macrophages, and we go to that site of infection, right? And then those macrophages are producing a lot of nitric oxide over a short period of time. And that's very important because that nitric oxide is toxic to the infectious bacteria, binds to the iron sulfur centers and shuts down their respiration. And as we discussed, it prevents the virus from attaching and replicating and propagating throughout the body. And then it activates what's called M1 macrophages. So that's the part that goes in and kills the infection, elicits a wound response or wound healing. But then what happens is that enzyme is only supposed to be active for several hours. And then you turn it off because you've gone there, you've isolated the infection, isolated the wound response, and now you switch the M1 macrophages to M2, which are anti-inflammatory, and what we call the Hill response. And then constitutive isoforms upregulate. But the problem in chronically inflamed patients, there's a chronic upregulation of iNOS. It never shuts off. It shuts down the constitutive isoforms. So now you have systemic nitric oxide deficiency. You're chronically inflamed. You have immune dysfunction, and you have oxidative stress. And those are the hallmarks of all chronic disease. But if we can restore the production of nitric oxide, we can downregulate iNOS, mitigate the inflammation, shut down the oxidative response, and repair the immune dysfunction we see in chronic uh, autoimmune disease, and including asthma.
Okay. So the next aspect then, okay, we talked about nasal nitric oxide. We were talking about the benefits of, say, nitric oxide that's produced inside the blood vessels. We were talking about the impact of it. Um, the production of nitric oxide then is typically derived from the foods that we eat. And that's also going to influence nitric oxide that's produced locally in the nose and the paranasal sinuses, but also in the blood vessels.
Well,
And
let me just make a point of clarity.
yeah,
These are two separate and independent mechanisms to produce nitric oxide, right? I think there is some crosstalk between it. Um, One can affect the other, but these are two separate independent pathways that one is dependent upon the function of the enzyme in the epithelium through nasal breathing and in the endothelial cells. The other is dependent upon the food we eat and the oral bacteria and stomach acid
okay,
production. But one can compensate for the other. But when you lose the ability to produce nitric oxide from both, which unfortunately a lot of people suffer from, then that's when you start to develop problems.
okay. So we lose the ability, say over time, then as we age, we're losing the ability of producing nitric oxide. So what you're saying is that is impacting both the nitric oxide production from the upper airways and the nitric oxide production in the blood vessels.
That's right. Because of the enzyme, because of the loss of function of the enzyme. So that we know typically declines with age. But we now know that that doesn't have to be the case, right? We can shift that curve to the left and rapidly accelerate it. We see it in young kids that have ED and 25 years old, ED, hypertension, diabetes. Their body can't make nitric oxide. And then you've got perhaps people like me and you. I'll speak for me personally because I know I'm 51, but I've got the vascular age of a 36-year-old. So I prevented, at least delayed this age-related loss of nitric oxide production because of what I do, what I eat. I think more importantly, what I don't do. I don't be exposed to fluoride. I don't use antiseptic mouthwash, and I don't take antacids. So now my body's primed to make nitric oxide. So when I do nasal breathing, exercise, or I take my supplement, I'm giving my body nitric oxide on a daily basis.
Okay. I was writing the Oxygen Advantage, I think it was back in 2015, and I talked about nitric oxide. And I can remember as well writing about beets. What I actually included as well, just going a little bit off topic and coming back to erectile dysfunction. Viagra as a drug was initially proposed for cardiovascular health. And when they administered it to the subjects, they found it obviously had other uses. But that was all based on nitric oxide as well, wasn't it?
Well, not necessarily. No,
Okay.
not. So the PD5 inhibitors, the Viagra's, the Cialis, the Levitras of the world, those are downstream of nitric oxide. So they're called phosphodiesterase inhibitors. So, we talked about nitric oxide being that first domino. Nitric
Mm,
oxide leads to an increase in cyclic GMP. And every cell in the body has what's called a phosphodiesterase enzyme. So it degrades cyclic GMP. So if you give a phosphodiesterase inhibitor, you prevent the breakdown of cyclic GMP. But in patients who can't make nitric oxide, there's no increase in cyclic GMP. So the PD5 inhibitors don't work. In fact, they can't work. So, and we know that today that Viagra was approved in 1998 by the FDA in the US. And today we know that 50% of the men that are given these PD5 inhibitors do not respond with better erections. And it's because their body's not making enough nitric oxide to lead to the accumulation of this second messenger. And so they're non-responsive. But no, the PD5 inhibitors have nothing to do with nitric oxide production. They potentiate nitric oxide-based signaling, but they do not affect nitric oxide production. And that's why people don't respond to them. So what we focused on is going, one step higher. Let's restore the production of nitric oxide. And then now in patients who take PD5 inhibitors, they can reduce the dose, making them much more safe, or they can eliminate the need for them altogether because we're restoring the body's natural physiology.
okay. So the production of nitric oxide, how to do that? or increase the production?
Well, I think you have to stop doing the things that inhibit it.
Mm,
So get rid of fluoride in your
yeah,
toothpaste, stop using mouthwash, and if you're on antacids, you have to get off of antacids.
yep.
And then once you stop doing the things that disrupt it, the other big thing is sugar. Sugar leads to sugar is sticky. It sticks to proteins and causes the enzyme to become dysfunctional. So you got to
Including
eliminate,
alcohol.
including alcohol. And so you have to eliminate sugar, go to a low glycemic index, eliminate sugar from your supplements, from your diet. And then once you eliminate those things, then you can do nasal breathing. You can do moderate physical exercise, 20 to 30 minutes of sunlight. There's certain wavelengths of lights and frequency that can release nitric oxide or stimulate nitric oxide release from metals and make that a labile source of nitric oxide. And then, when all else fails, we've developed technology that does it for you. So if your body can't make it, then we have product technology that provides it for you.
I think the supplement is very interesting. I bought them when I was in Austin. I don't typically talk about supplements. In actual fact, this is the first podcast I have spoken about supplements. This one here is your supplement.
Right.
And it was more so on the base that I understood about nitric oxide, the role it plays. And I just felt that, yeah, this could be very, very interesting. And I've never actually seen nitric oxide as a supplement in the health food store. Maybe I just was looking in the wrong place. Now, I'm in Ireland. It seems that nitric oxide has been kind of overlooked still, even in terms of people going into a health food store, having various issues. Like, I'll give you a comparison. So many people my age, including friends, have high blood pressure. No doctor has talked to them about nitric oxide. They've talked about taking different drugs, ramipril and different drugs to help lower high blood pressure. But nitric oxide is overlooked. But yet nitric oxide seems to be the most obvious one. Is there any side effects, by the way, from taking a supplement of nitric oxide?
No, not when taken as directed. I mean, there's dose dictates toxicity. The only
Mm.
signs of toxicity are taking too much. You would have an unsafe drop in blood pressure called hypotension, or you develop a condition called methemoglobinemia, where too much nitric oxide can oxidize the iron of hemoglobin and reduce the oxygen carrying capacity of the red cell. But you don't see that. We've never seen it.
It had to be
Uh,
really high doses.
it would have to be really, really high
Yeah.
doses. Yeah, but again, we talked about it. 50% of the people that are prescribed antihypertensive medication, whether it's amlodipine, um, ACE inhibitors, lisinopril, ARBs, things like that, don't respond with better blood pressure. 50% of the medication used to treat people with high blood pressure don't work. And the reason for that is because it's not addressing nitric oxide. And I believe probably 95% of the hypertensive cases is due to a loss of nitric oxide because of the physics problem, right? Same amount of volume of blood going through smaller pipes, pressure goes up. If we can provide nitric oxide, dilate the blood vessels, we fix the physics of hypertension. And it's so very simple. The supplement does that. And so, our whole thought process dating back 20 years ago was, look, if your body can't make nitric oxide, then we got to do it for you. So that lozenge is really what we call a solid dose form of nitric oxide gas. When you put it in your mouth, it dissolves over 5 minutes, and it's releasing 20 to 30 parts per million, the same amount they give to premature babies with pulmonary hypertension. So we try to train people, put the lozenge in your mouth and deep breathe. Because number one, it's going to provide a source of nitric oxide. Number two, we're restoring the ecology and the diversity of the oral microbiome because it's an orally disintegrating tablet. And then number three, we understand the enzymology and the biochemistry where we actually fix the enzyme in the upper airways and in the endothelium. So now that lozenge is improving your body's natural ability to make it on its own. So put the lozenge in your mouth, do nasal breathing. It takes 5 to 6 minutes to completely dissolve. And again, it's stack the hack. You're delivering nitric oxide to the airway. We're improving tissue oxygenation, blood oxygen saturation. We can mobilize stem cells. We can normalize blood pressure, improve oxygen saturation. We did this during COVID. We had a drug trial, a phase 3 trial during COVID with the nitric oxide, and we made people better and kept them out of the hospital.
Yeah, it's pretty amazing. I think there was one published paper, a review article on nitric oxide. Could nitric oxide help to mitigate the effects of COVID-19? And they did include in the article the importance of nasal breathing, and increasing the production of nitric oxide. But other than that, I didn't really feel I couldn't find all that much.
Yeah.
Drawing it.
In the US,
Yeah.
you made a comment that you didn't see nitric oxide based products as we're increasing awareness, which hopefully this podcast can do. There's hundreds of so-called nitric oxide products in health food stores, in pharmacies. But the problem is 99% of them don't provide any nitric oxide benefit because they're giving these patients the precursors or substrates and hoping their body can convert it. But again, if the enzyme is dysfunctional, then these arginine, citrulline-based products can't work. If you don't have the right oral bacteria, the nitrate, the beetroot-based products can't work. If you're taking antacids, they can't work. And so what we do is completely different. Is if your body can't do it, then we provide it for you. And in fact, I coined a new term called Nitrauticals. So nutraceuticals are like dietary supplements. I'm not a nutraceutical because most nutraceuticals don't work. They don't do anything. So what we do is called Nitrauticals, which is a term that I trademarked because in that word is nitric oxide. We
Mm-hmm.
can provide nitric oxide that we can detect, we can quantify and verify that these products are generating nitric oxide gas.
Oh, I think it's been a wonderful conversation. Just tying everything in together. Okay, so we started off with this at the very beginning about the importance of nasal breathing, not just during rest, but also during physical exercise. You spoke about doing your press ups and your squats, very impressive, with your mouth closed, and also during sleep. Um, Other aspects in terms of does the speed at which you breathe also influence, is it the production of nitric oxide or is it just because you're breathing slower that you're going to capture more of the gas? Can you speed up the generation of the gas inside the nose?
Well, I think you can, but again, there's some chemistry that's occurring because nitric oxide can react with oxygen. And without getting too technical, this is a second order reaction with oxygen. And so you have to have a normal, and that's why it's so important to regulate the oxygen delivery and the flow rate in inhaled nitric oxide therapy because you don't want to facilitate the dioxygen reaction and form what we call nitrogen dioxide, which is a toxic pulmonary toxicant. So I think in normal breathing, we're activating these mechanoreceptors on the epithelial cells producing nitric oxide, and just during normal breathing. And I don't think it affects because typically we have much higher concentration of oxygen than we have nitric oxide. Because nitric oxide is so potent, you don't need a lot. And so the simple kinetics of this physical chemistry that occurs with oxygen and nitric oxide, oxygen is so far in excess that unless you typically don't get it with normal breathing patterns. But I think normal slow breathing during sleep is effective. I think if you're doing rapid breathing during high intensity interval training, the data show that you can produce nitric oxide in the nasal cavity. It's vasoactive, it's dilating blood vessels systemically. So there doesn't seem to be a limitation in that regard.
Swift is a researcher back in 1988, and he found when people continuously switched from mouth to nasal breathing, if they continuously breathe it through their nose, the PO2 in the blood increased by nearly 10%. Now, that's the partial pressure of oxygen, as you know,
Yeah.
which in turn would influence the SaO2. It's possibly nitric oxide. That's that mechanism. Is it because of the redistribution of blood throughout the lungs, the dilation of the airways, and also the dilation of the blood vessels?
No, I think it's all of that. In 2015, it was published that nitric oxide is the cardiopulmonary cycle is a three-gas system. So you need nitric oxide bound to hemoglobin for oxygen to come off hemoglobin. So without nitric oxide being bound to that beta cysteine residue on hemoglobin, you don't get oxygen uptake and you don't get oxygen delivery. So when we increase nitric oxide production, we're improving tissue oxygenation and we're improving oxygen offload of hemoglobin when it goes from the arteries to the veins. So we're improving blood oxygen saturation, we're improving oxygen delivery to individual cells of the body, and we're more efficiently taking up CO2, preventing lactic acid production, and we're exhaling CO2 in the exhaled breath. But that entire cycle cannot work without nitric oxide.
That's amazing because if we look at the oxygen dissociation curve and we think of oxygen being carried bound by hemoglobin, I've never seen nitric oxide being mentioned. We talk about carbon dioxide, we talk about resultant drop to blood pH, we talk about temperature, 2,3 dysphosphoglycerate, no
Right.
nitric oxide. So basically for the lay population, I won't keep you long. Nitric oxide is going from the nose into the lungs, passing into the blood. So in the blood it's bound with hemoglobin.
That's right.
And hemoglobin then It's nitric oxide that is influencing the release of oxygen from the hemoglobin to the tissues. It's
Absolutely.
amazing.
It's the
Wow, that was
hemoglobin has to go a
2015.
conformational change, right? We call that the Bohr effect, and nitric oxide is part of the Bohr effect. In fact, I think it's more important than the drop in pH and the 2,3-DPG because none of that works. Those are consequences of lack of nitric oxide production that explain the Bohr effect. So that's why this is such a foundational molecule because everything, kind of propagates from that.
Wow. Nathan, it was a fascinating conversation. So, wrapping it up very, very quickly, we were talking about the importance of nasal breathing. It's very important that your body is able to produce nitric oxide. Your supplements, can they be bought in Europe, by the way? Nitric oxide?
We ship to Europe. We're working on a UK and EU distributor now to where they can be, because of the import taxes and the cost of shipping, we're trying to make this more cost effective. But yeah, the supplements can be found at n101.com. That's the letter N, number one, letter O, number one dot
Okay,
com.
we'll put it into the links as well. Then don't do the things that harm the production of nitric oxide, such as fluoride and mouthwash. Um, I'm assuming eat good foods, do regular exercise, nasal breathing, it's all there. Listen, it was a pleasure. Thank you so much. I think it was brilliant. I could talk for another hour, conscious of time. So your website again for people if they want to delve a little bit more.
N101.com for the product technology, but I encourage people to subscribe to my YouTube channel, Dr. Nathan S. Bryan Nitric Oxide, for education, awareness, information around nitric oxide. I just published a new book. I'll shamelessly plug my book. It's called The Secret of Nitric Oxide: Bring the Science to Life. We talk about nasal breathing. We talk about this cardiopulmonary cycle, but you can get that on Amazon, Barnes and Noble, or go to nathansbook.com and it'll redirect you.
Great. Pleasure. Well, enjoy the rest of the day in sunny Florida and thank you very much
Thank you,
and
Patrick.
all the
Take care.
best.